In this video, we'll discuss thyroid ophthalmopathy, the structures affected in thyroid ophthalmopathy, its pathology, and its consequences. Thyroid ophthalmopathy occurs in Graves' disease. It's a bilateral condition, usually in Graves' disease, but 10% of cases may be unilateral, and 10% occurs without Graves' disease. Does it occur in hypothyroidism? Yes, 5% of cases occur in hypothyroidism. So, a bilateral condition in Graves' disease, and 10% without Graves' disease, and 5% in hypothyroidism. What happens in thyroid ophthalmopathy? There is bulging or protrusion of the eyeball that causes damage and visual loss. What conditions worsen thyroid ophthalmopathy? Smoking and radioactive iodine, they worsen ophthalmopathy. Smoking is a major risk factor for thyroid ophthalmopathy and also for Graves' disease. What are the features of thyroid ophthalmopathy? Enlarged extraocular muscle, increased retrobulbar fat, lid retraction, increased intraocular pressure, optic nerve compression, proptosis, and corneal ulceration. How many patients of Graves' disease have enlarged extraocular muscle? Clinically, some of the Graves' disease patients have enlarged extraocular muscle, but on ultrasound or CT, almost all patients have enlarged extraocular muscle. What causes enlargement of the extraocular muscle? It's the muscle swelling and fibrosis. Why muscle swelling and fibrosis occurs? Cytokines play a major role in thyroid ophthalmopathy. Increased synthesis of glycosaminoglycans trap water, thereby leading to characteristic muscle swelling. And why does fibrosis occur? Extraocular muscles are infiltrated by activated T cells. Release of cytokines such as interferon gamma, TNF, and interleukin-1. Cytokines results in fibroblast activation, and late in the disease there is irreversible fibrosis of the muscles. Increased retrobulbar fat also causes tissue expansion. Lid retraction is due to sympathetic overactivity and increase intraorbital pressure. What does it causes? It can lead to proptosis, diplopia, and optic neuropathy. And what's proptosis? In the earliest form, sclera is seen between the iris and the lower lip, but in advanced cases, sclera around the cornea is seen on all sides. It affects 1/3 of patients and may cause corneal damage, especially if eyelids remains open during the sleep. What causes diplopia and how many patients it occurs? Diplopia occurs in 5 to 10% of patients, especially if they look up and laterally, and this occurs due to muscle fibrosis and increase in intraorbital pressure. And what's the most serious complication? Most serious complication of exophthalmos is compression of the optic nerve. 5% of the patient have compression of the optic nerve at the apex of the orbit, leading to what? Papilledema, peripheral visual field defect, and permanent loss of vision if left untreated. Optic nerve involvement and corneal damage is an emergency, and that requires high dose glucocorticoids. What if? When glucocorticoids are ineffective, orbital decompression by removing bone from any wall of the orbit. Radioactive iodine treatment, as I already told, worsens the eye disease, especially in smokers, which is a major risk factor. What's the clinical course of ophthalmopathy? Does not follow the thyroid disease, worsens in the first 3 to 6 months, plateau phase in the next 12 to 18 months with a spontaneous improvement, particularly in the soft tissue. Treatment: there is no treatment in a mild form. Control thyroid hormone levels and stop smoking.